Hello, I'm Michelle Kittleson, Professor of Medicine and Director of Education in Heart Failure and Transplantation at the Smith Heart Institute at Cedars-Sinai in Los Angeles. I'm here with my colleague, Dr. Ahmad Masri, Associate Professor of Medicine and Director of the Hypertrophic Cardiomyopathy Center and Cardiac Amyloidosis Program at Oregon Health and Sciences University in Portland, Oregon. Welcome to this program titled Cutting Edge Updates in Cardiac Amyloidosis, What's New for Patients? So as you may know, cardiac amyloidosis is a condition where there's a protein the body produces naturally that for reasons we don't fully understand deposit into places like the myocardium, resulting in a restrictive cardiomyopathy. Historically, transthyretin cardiac amyloidosis was almost universally fatal due to under-recognition and underdiagnosis, so patients were often diagnosed in the late stages of disease at the time they had advanced restrictive cardiomyopathy and poor outcomes. However, the field has transformed over the last few years with cutting-edge advances in diagnosis, as well as treatment. In 2019, the first drug was FDA approved specifically for the treatment of transthyretin cardiac amyloidosis, and now a second drug was recently approved. So today, we're going to discuss newly approved treatment options in the US for patients with ATTR-CM. And my first question to you, Ahmad, can you give us a brief explanation of ATTR-CM and discuss the burden it places on patients?
Thank you for the great introduction, Dr. Kittleson. So, it's really a disease that we have been talking about a lot lately. And it's driven by a few things. One, the fact that there is recognition of the real prevalence of the disease. And as you mentioned, it was a fatal disease, and now we have tools that can address this. And so from a pathophysiology perspective, we all have transthyretin. The old name is prealbumin. So it circulates in the body, released by the liver. It likes to circulate in a tetramer form, so it constitutes of 4 parts. That makes it stable. And there are different binding pockets to different things that exist in our body. It has minor functions as we get older, as far as we know. And so the disease happens in certain individuals. More than 90% of them don't actually have an underlying alteration to the TTR gene, but they still get the disease, which what we call wild type. And that happens when this tetramer misfolds and falls apart and becomes singulars or monomers. And these monomers misfold just in the right way to cause these aggregates of amyloid fibrils. They typically affect the heart mainly in this population. However, it's important not to forget that 10% of the patients or so have actually a variant or a mutation in their TTR transthyretin gene that they're born with, but manifests at later stage in life. If you live in certain areas like Portugal, for example, it can be as early as in the 30s, mid-30s to mid-40s, where patients have neuropathy as their first manifestation of the disease. And so as you get outside of such areas, this gets pushed out another 10 or 15 years for these patients with neuropathy, cardiomyopathy, or mixed phenotype. And so the way that TTR cardiomyopathy presents, it can either be asymptomatic, which is the extreme minority of patients, because simply these patients are active. They have typically have had a good life, and they're taking care of themselves. And so we don't have a lot of comorbidities that exist at the same time. So by the time they really start getting that shortness of breath, that leg swelling, feeling exercise intolerance, they already have the disease well established. And so we have to think about this when we see someone with a HFpEF phenotype, someone with aortic stenosis, with really LVH, that nowadays, when patients are presenting so early with AS, you don't expect to have significant severe LVH, especially if it's affecting also longitudinal strain in a major way. If someone is presenting with unexplained conduction disease and disorders when they have no risk factors, but yet they need a pacemaker, or they have really progressive conduction disease. And then not to forget hypertrophic cardiomyopathy. It's something we see all the time where patients are told, oh, you just have HCM. But the reality is that they had already enough red flags to suggest that it's TTR. And the bottom line is the following, is that this shortness of breath, this heart failure syndrome that associates with TTR cardiomyopathy, leads to significant impact on the quality of life. Patients essentially stop doing what they normally do in their living, and with a progressive fashion to the point where they end up coming into and out of the hospital with heart failure episodes, arrhythmias, eventually leading to death if it's not addressed.
Amazing. That was such a great overview. And I'm going to really pick out some of the very important things you just mentioned. When you have shortness of breath, your job as a clinician is to understand why. And if you have increased LV wall thickness on your echocardiogram, you have to figure out why. Is it that the muscle is thick, or is there infiltration into the muscle? And you have to look for the other clinical clues that might suggest the diagnosis, such as aortic stenosis, conduction system disease, things like the extracardiac manifestations like carpal tunnel, spinal stenosis. The scope of this is not diagnosis, and there's plenty of amazing resources to look into that. But remember, the first hurdle, high index of suspicion. Second hurdle, order the right tests, interpret them in the right way. And finally, the third hurdle, which is treatment, which we're going to focus on now. So for the past 5 years, the only agents approved for the treatment of ATTR-CM have been the TTR stabilizers, namely tafamidis. Can you tell us a little bit about TTR stabilizers and tafamidis?
Sure thing. So as we mentioned, transthyretin protein likes to circulate in a tetramer form. And really a major step in the pathway of this disease is when this tetramer form falls apart and becomes dimers and monomers. And so one simple strategy is to go after this tetramer and prevents it from essentially falling apart. And as you mentioned, tafamidis was the first FDA-approved agent based on the ATTR-ACT trial. And what it does is that it binds to where the thyroxine hormone normally binds. TTR transports less than 5% of the thyroxine hormone, so it's not really an essential job for it to do. And so we take tafamidis, which goes and binds to that pocket, making the protein more stable and preventing it from falling apart. Acoramidis, on the other hand, which is the second TTR stabilizer that just got approved by the FDA, also for the same indication for TTR cardiomyopathy, for prevention of for prolonging survival, prevention of mortality and heart failure related hospitalization and CV events, also binds to the TTR tetramer. It binds in a different pocket, and it's actually a very interesting development story for those of you who are interested in it. It comes on the heels of the discovery that there is a super stabilizing mutation or a variant that was discovered in Portugal called T119M. And if someone has that variant, even if they have another variant, they actually don't have the disease or have a much less severe phenotype of the disease. And so based on that, this drug was designed to bind in a different pocket than tafamidis. And it does lead to more or stronger stabilization, obviously not compared in a head-to-head fashion. And acoramidis was evaluated essentially in different trials that I'm sure we'll be discussing as well.
So tell us a little bit more about the ATTR-ACT trial. Tell us the evidence that tafamidis is effective that led to the FDA approval.
Yeah, definitely. So the ATTR-ACT trial was published in 2018, and it really was a landmark and a pivotal moment in taking care of this group of patients. The reason is, it used to be said that, well, why would you want to run after this diagnosis when you have no treatments for it? So it's more of an academic mission. And I would argue that wasn't true, because if you don't understand the disease and what the patient has, how can you even evolve over time? But at least with ATTR-ACT, now we started saying we have a treatment. And so ATTR-ACT showed that there was about a 30% reduction in all-cause mortality and about a 30% reduction in heart failure hospitalizations between placebo and tafamidis. And tafamidis had 2 doses in that trial, but they were put together for the purposes of analysis. It also showed that deterioration of 6-minute walk test as a measure of function was much less over time. Deterioration of quality of life as measured by KCCQ was less over time as well. However, what it also showed us is that there is still significant unmet need. 30% of the patients or so still died during the follow-up phase. And when we look at the long-term extension arm, which was up to 70 months or so, 50% of patients on tafamidis died over that follow-up duration. And before people say that, well, they're old people, they're going to die of something, The reality is that if you look at the causes of death, more than 70%, if not even more, of these were still cardiovascular death. As I said, these patients typically have lived good lives, have taken really good care of themselves. They don't have significant burden of comorbidities. If you have ever taken care of them, many of them tend to be on the active side, athletes and whatnot. And so the expectation that if someone hits 80, they should essentially just, move on is not an accurate, anticipation of how things should evolve. And so regarding Accreditation itself, so that was for tafamidis and ATTR-ACT. And from there, the FDA approval came in 2019, as you mentioned. And since then, this drug has been used tens of thousands of times and is already approved in many, many different areas as well around the world, not just the United States. When it comes to Accreditation did the same thing, went through the phase 2 and phase 3 trials and evaluations. We'll focus on the phase 3 trial called ATTR-CM trial. And just to preface this, when these trials were designed, the patient population evolved over time. So the natural history of the disease changed because we started finding these patients slightly earlier. They still all have disease, of course, and they still all have symptoms, but they're not too late in the stage when it comes to this disease. And so what was surprising from the ATTRibute trial overall, that everybody did better, correct? Not just the treatment group, but also the placebo group, if you compare them to ATTR-ACT. Nonetheless, these patients actually benefited tremendously from being on Accreditation. And the primary endpoint, and you can go and dissect it, but the primary endpoint had multiple components to it. I would argue that the most important piece is that it still led to improvement in survival and cardiovascular related hospitalizations, prevention of worsening in functional capacity as measured by 6-minute walk test, as well as less deterioration in NT-proBNP and in quality of life measures and all whatnot. One thing that emerged that I really liked seeing from ATTRibute-CM is that the time to see a difference was 3 to 4 months, and that is driven by cardiovascular hospitalizations, obviously not mortality, but that's really a call to pay attention. This idea over the years that this disease is chronic, you can take 6 to 12 months to figure it out and find patients and treat them, is actually false at this stage. You need to find patients early, you need to find them quickly, and you need to institute therapy, because we can prevent a cardiovascular hospitalization as early as 3 to 4 months of treatment, which is a major pivotal change in the natural history of the disease. And finally, we also looked at open label extension data that showed continued separation in these curves, even when people end up switching, which emphasizes the need for earlier treatment between, early treatment in these patients with transthyretin cardiomyopathy.
I think that was such an amazing overview, and I want to highlight a few really important points that you brought up. Number one, this is a triumph of translational medicine. Amyloidosis is truly a triumph in the sense that an understanding of how the happy, stable tetramer exists has led to insight into these therapies that just do one thing. They just stabilize the TTR protein, which makes them very well tolerated, very easy to give, and they prevent progression. I think it's so important to highlight those things. Now, you told us about the 2 landmark trials we need to know about: ATTR-ACT 2019, tafamidis, and now, of course, ATTRibute-CM, acoramidis. And just in November 2024, of course, acoramidis is now FDA approved for the use in patients with TTR cardiac amyloidosis. Tell us about the similarities and differences between these 2 agents.
Great question. So they're both oral medications. They do work in different ways, but they essentially, there are no head-to-head comparisons. And so from our perspective, we consider them to be equal drugs at this stage when it comes to hard endpoints or hard outcomes or whatever you want to call it, from death and CV hospitalizations. They're both very well tolerated. Virtually, really, I know the labels have long list of things. We have used together. We have used these for a long time right now, including Accreditation in different clinical trials. Really, they're very well tolerated. I mean, when someone comes and says, I have a side effect of the drug, you have to really drill into it. There are some drug-drug interactions, so pay attention to that. One thing that people actually frequently forget is tafamidis and statins, especially rosuvastatin in high doses can interact there, so pay attention. In terms of the differences there, binding starts are completely different. And so the dynamics and the mechanics of the disease, how it gets stabilized with acoramidis is different from tafamidis, even though we say they're the same class, the mode of action is different ultimately. And so acoramidis leads to stronger, more potent stabilization. This is at least preclinically. We can't prove it because we don't have head-to-head trials yet that are available for the drugs in humans. And in terms of acoramidis, it did generate data that at least, excites us, the people who take care of a lot of these patients, that the stronger or the more stabilization that is produced by use of acoramidis, even down to the 1 milligram per deciliter of TTR level, leads to better probability in terms of survival and benefit from the drug. And so the key message is that, maybe in this scenario, more is better, but we need to confirm that.
That's a great point. I'll turn it over to you. What questions do you have for me?
Yeah, I have many questions. I have to keep an eye on the clock, but I'll start with one. How do you expect? So whenever a new treatment comes out, people start asking, well, how can we use this? How can we think about this? But the question that I have is, how do you expect this to impact the current standard of care for patients with TTR, and how do you see it fit yourself?
Yeah, these are great questions. And as you so importantly pointed out, there is no head-to-head trial of tafamidis and acoramidis. This is good news for patients in that they both work. Both of these agents reduce cardiovascular death, heart failure hospitalizations, cardiovascular hospitalizations in patients with TTR cardiac amyloidosis. They both work. And you might say, well, even if there isn't a head-to-head trial, can you just compare the two trials and tell us what you think? Actually, no, we cannot, because as you also so beautifully pointed out, the patient populations are so different because we, as a community of clinicians, have gotten so much better at diagnosis, at early diagnosis and treatment of our patients. So even the placebo arm of ATTRibute-CM does better than the treatment arm of ATTR-ACT. 5-10-year difference in between the enrollment of these trials, and you see a dramatic difference. This is a wonderful news for patients. If you go and Google this disease, you shouldn't, because the benefits and the outcomes are constantly improving. So back to the question. I cannot rely on clinical trial evidence to tell me which one to use. So it comes down to judgment and experience and practical aspects, meaning which one may offer better coverage through my patient's plan. And really, it comes down to that. When you have two medications that, for as far as we know, both have efficacy, which one is more practical for my patient to take? We have no evidence there's difference in tolerability. They both only do one thing. As you said, the side effect profile is minimal. So it's really just about which is easier to get for my patient. Tell me, do you agree with that?
I fully agree with that. And, I think the other scenario where one can think about this is, when you have singular option, every time you see the patient, even if they're unhappy, you just tell them, I'm sorry, there's really not much we can do. This is a pivotal moment, I think. If you think just about hypertension management, if someone doesn't enjoy being on candesartan, we can pivot to something else within the same family. And, not that we necessarily have always to do this, but this is a scenario where having options is really an important addition to our tools here.
And I think the other thing to keep in mind too is that there's more agents on the horizon. So the treatments for TTR cardiac amyloidosis follow this very pleasing pathophysiologic progression. The TTR protein is the problem. You could silence the production, you could stabilize the protein, you could suck it out of tissues. Well, not quite ready for prime time yet. We have two stabilizers now. They keep the protein in its happy tetramer form. On the horizon, we have a silencer that will stop progression. So what we will likely be discussing over the next year will be, how do we add that to our armamentarium? But we have to remember the current agents that exist or on the horizon do not reverse disease. They slow, hopefully halt progression. They do not reverse disease. Another plug for early diagnosis. Freeze your patient as early as possible in the progression by having a high index of suspicion and ordering the right tests in a timely fashion. But we can hope for these monoclonal antibodies on the horizon at some point in the future that may reverse disease. And I think this becomes hugely important when you are managing expectations, discussing the disease with the patient. So I'm going to tell you my approach, my spiel of how I explain this, and I'd love to hear your insights. So this is what I say. I say, number one, don't Google it. Number two, getting TTR cardiac amyloidosis in many situations is a disease of winning the game. Congratulations. You got old enough to get this condition, and you chose to get it at exactly the right time when there are treatments that through early diagnosis and accurate diagnosis will allow you to slow the progression at a very early stage and preserve your quality of life and functional capacity for as long as possible. And we know with successive trials and iterations that we are reaching the point where patients living with cardiac amyloidosis may even enjoy the same age-related morbidity, mortality of patients without amyloidosis. The future is so bright. And the second thing I like to pay attention to is knowing about the right heart failure management. Remember that it's a different animal than, say, something like heart failure with reduced ejection fraction with the 4 pillars of guideline-directed medical therapy. Often it's more like a HFpEF, or even if the EF is mildly reduced, they have this restrictive physiology with intolerance to vasodilators and beta blockers because they're very reliant on their stroke volume or their fixed stroke volume. So I have a low threshold to pull back on any agent that causes fatigue or orthostasis, like vasodilators and beta blockers. So that's my take on the overall management, which I think as clinicians that has allowed us to improve outcomes and manage expectations. Tell me your take.
Well, you've laid it out really beautifully. I think, we can probably shortly move to questions Q&A, but I'll just add one more point there that, I think these ancillary approaches to treatment are so important. Patients don't feel a lot different by being prevented from worsening. Patients feel different by these other things that we do, from optimally diuresing them, removing these agents that are making them feel, poorly, essentially. And so there's such an important point. I'm always being asked in the last, few weeks, how will I think about this in my own clinic? And I think for me, there are two groups of patients. One easy group, which is those who progressed on tafamidis, those who don't feel content on tafamidis. I think that's really, an easy discussion in a way. Because well, there is another option now compared to when we say just deal with it or consider clinical trial. So that's, I think, is a rather easy group. Even though we can't promise patients anything, at least they get to try, and we know for a fact that they will not be losing something from switching over. The second group is these patients who will be newly started on different medications, and I think, like other diseases, we should just have a really rational discussion with the patients. I think this is a scenario where science will win and triumph in the end of the day. The more data you produce from your studies and clinical trials, the more confidence you're going to instill in people. I definitely really like the data that I've seen about degree of stabilization or probability of an outcome. I use TTR level in my practice just to learn as we go. We're not necessarily basing decisions yet on it, but having a second option, I think, will open the door on learning more about this.
That is so helpful, and especially for someone like you who has really participated at the cutting edge of these clinical trials. That's such important insight. So I'm going to ask a question. I'm going to poke you with a question from the audience. Now I'm going to give you the question, and then I'm going to give you my answer, and then let's see if we can generate some controversy. Okay, so here's the question. How do you monitor the efficacy of the agents you give? Now, you mentioned the TTR level, so I'm going to tell you my take. And I think everyone has a temperament as a clinician, and I tend to be a parsimonious minimalist, meaning if it's not going to change what I do, I don't have the evidence to know how it should change what I do, I don't check it. So I would argue that serial assessment of markers like 6-minute walk or NT-proBNP or troponin or TTR levels currently in the tail end of 2024 do not offer us any insight into how to manage our patients better. I struggle with figuring out how to follow patients clinically, if there's any way to do it. Tell me your take.
Yeah, so I agree with you that there are not a lot of things to acutely or actively do to change the trajectory. But I do think that, this is a disease that even in a busy center, you have about 300-400 patients. There are some centers with 1,000 or so, but the majority have few hundreds. And, if you want to learn about the behavior of the disease, having some objective markers really help, because when patients show up and say, I feel terrible, and you have some assessments that can objectively allow you to think about why they feel the way that they feel, it's really for you, not for the patient. Sometimes it's really for you as a physician to essentially put that compass on and start to understand different behaviors of the disease, understand your own population, because I don't think, these studies that come out of centers that have, many hundreds or thousands of patients necessarily reflect, a small center in, Southeast United States, for example, or a center, in Pacific Northwest, correct? And so I think that's where this helps. I don't think necessarily that it will help us base the decisions of how we do things. I care more about how the patient is doing, their need for diuretics, their progressive heart failure. To me, essentially, it's really a no-brainer if someone continues to have progressive heart failure that we need to try something else, for example.
Excellent. We're going to end with a final question. I'm not going to go easy on you. It's a very hard question, and I'm dying to know your answer because I'm not sure of the right answer here. So we're looking at the future landscape where we will have stabilizers and we believe we will have silencers. So the question is, if you silence something, do you still need a stabilizer? If you stabilize it well enough, is a silencer, meaning will there ever be a role for combination therapy in patients with ATTR-CM?
Well, there might be in the future, but I don't think there is one now. I know it's easy to say why not keep adding stuff on, but we're talking about a very, very, very expensive why not. And also, it's back to the principle of medicine. If we use a drug, even if it has minimal side effects, we need to ensure that it actually is beneficial. If it's not beneficial, we should not be using it. If we're silencing TTR by 80%, for example, and we're giving a stabilizer like tafamidis, which is what's been the common combination that gets done sometimes, how do we know we're actually providing any benefit by adding tafamidis? We don't. And so there are some very, very small subgroup from studies, including the most recent HELIOS-B of vutrisiran and tafamidis, showing maybe there is advantage, but I would argue that these are so subgroup selected, hypothesis generating only, and not to be used to inform clinical practice. The CardioTransform trial of eplontersen, another silencer, has about 1,500 patients. We'll have 4 large groups that we can maybe compare and have some indirect evidence there. But I would say that for now, we shouldn't consider combination therapies. There are some rare exceptions where you can't really silence the patients, well, when they have a very aggressive variant or whatnot, something is going on. So maybe, but on average, in most patients, we shouldn't really be considering this at this stage.
Well, folks, you heard it here. I can't imagine any more amazing, clear, practical advice to help you care for your patients with cardiac amyloidosis. Have a high index of suspicion, order the right tests, and the future is bright with now 2 FDA-approved therapies for your patients, tafamidis, acoramidis. Thank you, Dr. Masri, for a great discussion, and thank you to the audience. I hope you learned a lot.
Thank you, Dr. Kittleson.